Good afternoon, everybody. Thank you very much for joining us today here at Health Monix as we are doing our second part of the 2023 final rule that was finalized about a week and a half to 2 weeks ago. Um, if you missed the first one, it was mostly on ACO information. Today's is going to be mostly on MIPS, and then we will be doing one in December that will cover the future of MVP. So stay tuned for information on that. Today, I am joined once again by Mara Flaherty. Hi, Mara.
Hi, Mike. Thanks for having me.
Oh, thanks for being here. Appreciate it. We will be going over everything with you and leaving time for some questions at the end. Just for your information here, you can see on the GoToWebinar widget that there are two sections I'm highlighting. The first one is for questions. Please feel free to ask your questions. We may not be able to get to them at the end, or if they are specific to you as a provider or as a group, we will get back to you after the call. As well as the bottom, you'll see the handout section. In the handout section, we have the copy of the slides from today, as well as some other things in regards to our products and programs here at Health Monix. You will be receiving an email later today, this afternoon, that will have a copy of this recording as well as the slide deck so that you may share it within your organization. So I'm going to turn it over to Mara to get us started.
Cool. Thanks, Mike. So getting right into it, just a quick review of what we're going to go over today. So this webinar is about the 2023 final rule for MIPS. So we'll go over just quickly program requirements and all that good stuff, and then we'll move into how exactly the final rule will impact you. And finally, how Health Monix is positioned to help you succeed with MIPS in 2023. All right, so the main objectives for CMS, so going through the final rule, we have identified some of the main themes. The first objective we identified is really promoting more meaningful participation for clinicians. So focusing on quality and improved outcomes, which is the main whole goal of this program. And then the second two objectives focus on successful implementation over the next few years of MVPs and APMs, which we will discuss in more detail as we go on here. All right, and then CMS vision for quality on a national level. Ultimate goal here is for our healthcare system to be high quality, safe, and equally accessible for all. This is going to be achieved by placing emphasis on the patient across all payers and throughout the care journey. And then lastly, they have CMS is taking considerations from lessons that they've learned and seen trends over the past 2 years of COVID and applied that to outcomes-based care. So the 2023, breaking down the final rule, so we will go over finalized changes to traditional MIPS, so things that we are all probably familiar with, and then we're going to get into more detail on MIPS value pathways or MVPs, which have been finalized for 2023, and then lastly, the APM performance pathway or APP. Okay, so MIPS reporting frameworks on a high level, this is really just kind of an illustration of your different reporting options and things you may or may not be eligible for and planning to report in 2023. So the overarching umbrella is MIPS. That breaks down into traditional MIPS, APM Performance Pathway or APP, which was launched in 2021 and is still continuing to pick up speed going forward and really more so into 2023. And then finally, the MIPS value pathways or MVPs, which have been finalized for 2023. So we have lots of information on that for you that we will get into here. So scoring policies, bonus point scoring, similar or it's the same as 2022. 75 points will be the minimum threshold to avoid a negative payment adjustment in 2023 performance year, 2025 payment year. And then another note to take notice of, in 2023, there will be no exceptional performance bonus. So this year, 2022, will be the last year for that, and is going away come next year, and that's been finalized in the final rule. So kind of breaking that down, what I just mentioned, the 75 points as the minimum threshold to avoid the penalty. On the left is what has been in place for 2022. So that breaks down the scoring and what that would look like given any score from 0 to 100. And then on the right, what this is illustrating is the 89 to 100, which was considered the exceptional performance bonus, is no longer applicable in 2023. So same idea, where anything above 75 will get you a positive payment adjustment. It's just eliminating that exceptional threshold above 89. So this is, again, just illustrating the comparison in scoring between this year, 2022, and next year, 2023. And then this slide, this illustration here is kind of putting that on a graph for you. So again, if you'll notice, anywhere between the 0 to about 19 MIPS points is where you're going to be seeing the maximum negative adjustment. So that'll be about a negative 9% payment adjustment that will be assessed to you. And then it's a sliding scale from from 19 points to 75, where that negative adjustment will be minimized. And then again, at the 75 point mark, that's where you'll start to see a positive adjustment that's on a sliding scale up to the positive 6% reimbursement. And this is for 2023. So MIPS reporting in 2023, breakdown of the categories here. This is the same as last year, 2022 as well, where quality and cost are worth equal parts, 30% each. The next highest category will be PI at 25% of your total MIPS score, and then IA at 15%. And then the eligibility remains the same as well. So low volume thresholds are the same for 2023 reporting, and then the same thing, 75 points to avoid the threshold. Okay, so MIPS quality, the data completeness threshold set at 75% of eligible instances per measure, regardless of pair. So this means you need to report on 75% of all of your patients per measure, not just Medicare. And the goal here is to not just use your best 75%. And really the reason it's 75 is to account for administrative issues and reducing the burden a little bit. And then moving on, CMS has removed many of the process measures, which we'll get into shortly here. And then in the quality realm as well, they are placing a heavy emphasis on drivers of health. And I'm going to turn it over to Mike to discuss measures and those quality parts.
Great. Thank you very much, Mara. All right. So when we go into MIPS, we're going to go over a couple pages here that are really going to be useful for you offline, not terribly able to read them on here and fully grasp what they have to say. But this first one here shows you, I've shown it every year, where it's the traditional MIPS quality measure overview, the number of measures they're planning to have for 2023, or they have for 2023 is 198. That does include 172 CQM measures, which are your registry measures, 47 ECQMs, which we can report here at HealthMonix, those are your EHR measures. And then they do have the addition of a survey measure as well as the 4 administrative claim measures. On the next screen, these are all of the new quality measures that are out there. You see psoriasis on there and dermatitis. There's 2 of the new ones. I'll point out, and we'll talk a minute about the screening for social drivers of health on the next screen. But we also have here a couple of kidney related measures, as well as you'll learn a little bit more on the bottom there of that adult immunization. So when it comes to the screening for social drivers of health, I'm going to point out right now, and I know Mara just said it a minute ago, but of the 3,000 plus pages of the final rule this year, I would say that over 200, maybe 300 times, social drivers of health was mentioned. It is important. They're creating measures around it, whether you're part of a MIPS program, you're part of an APM or an ACO, or you're even part of driving a registry or an EHR. Social drivers of health has become the #1 talked about thing in all of the macro realm. So factors beyond the clinical realm are directly associated with patient health outcomes. Social risk factors account for 50 to 70% of health outcomes. I found this one interesting. In 2018, 8,500 physicians were surveyed, and they said 90% of respondents reported that their patients had serious health problems linked to the poverty or social conditions. So that's really, really important, and it's brought up a lot. This measure is going to calculate the percentage of patients 18 or older screened for food insecurity, housing instability, transportation problems, utility difficulties, and interpersonal safety. I know they've added one measure this year. Wouldn't be surprised if social drivers aren't in improvement activities moving forward as well, and possibly in a cost score as they continue to grow. Some of the removed quality measures or all of the removed quality measures are here. Not all of them are very popular. I know, for instance, 76 is used a lot of times, as well as my history and dermatology. 265 was used all of the time and now will not be available moving forward. One of the important measure changes that you'll see this year, 2 of the top 10 most used measures according to our registry, measures number 110 and 111, which are for the flu and pneumonia vaccines. Those measures are being combined into one measure, and it will include both the flu and pneumonia as well as the Zosur vaccination and Tdap. So they're all going to be included under one measure in MIPS. However, they will still stay the same for the CMS web interface APM measure, as well as for APP measure, as well as for MVP reporting in the future they'll be available for. But they are gone as of 2023, the 110 and 111 as you know it. Here's a bunch of numbers. These are all the measures that have substantive changes. As I've mentioned before, CMS makes it sound really big and all these major changes with these measures every year by calling them substantive. I think what we really want to share with you is that a lot of these had coding changes, whether it is added a ICD-10 code into it, or they increase the number of types of providers that can report, as clinical social workers are now needing to report across the board. They've added them as a measure denominator, as well as how to answer some of these questions have changed. So if any of these measures are ones that you have reported or will planning on to report, just take a quick look at it. Right at the end of the final rule, all of the measures say what changed on each one of them, or HealthMonix will have that information out as our measures are updated in our system. The ones in red aren't anything special besides the fact that they are common measures that we see reported on a regular basis that have changes to them. So just please take note of these. You'll have it in the slides when you get the slides later today, or if you grab the handouts that we have here. So cost performance category here, there weren't a ton of changes in the cost category. They really tried to keep most of it the same. The 2 changes that really came across is that there's now a maximum cost improvement score of 1 percentage point out of 100 percentage points available for the cost performance category. That's going to start in 2022. They finalized it moving forward as well. Also finalized to update the operational list of episodes so that MSPB, as we know it, is changed to MSBC. MSPBC cost as a care episode group. So it's moved in with the other episode measures that we have. So you have the 25 total cost measures. Attribution is based off the provider specialty and services. Episodes are triggered based on services that are billed. Really understand that if you want to learn more about the cost category and how it's going to impact your overall scoring, you can take a look at our cost webinar that we've put on, as well as there will be a couple of blogs coming out in the near future. But cost was 30% of your score this year, and we need to make sure that you are staying ahead of it. Every measure on the cost side is risk adjusted based on the patient risk factors. So seeing sicker patients is not harming your score, and actually it can reduce the risk, or increase the risk on your patients and increase your score based upon that risk. So, and all applicable measures scored and averaged into your provider cost category score. Not every provider has a cost score. You have to qualify and meet the case minimums for any of the categories to have a cost score. So if you have questions about that, once again, we do have plenty on our website, but you could also reach out to me directly. You'll have my information after this. All right, I'm going to throw it back over to Mara, and she is going to go over our favorite, promoting interoperability.
Thanks, Mike. Yep, so promoting interoperability, like I had mentioned earlier, worth 25% of your total MIPS score, again in 2023. So this table here, just listing out all the measures we have available, again, broken down into 4 objectives. All of the measures here listed are required except for the last one in the public health and clinical data exchange is the only optional or bonus measure for this year. And then if you go to the next slide, we'll get into more of the measure specifics.
Sure, sorry, clicking issues,
Go
ahead.
You're fine. So the query of prescription drug monitoring program is a new measure, or sorry, it's newly required for 2023. It was previously an optional measure worth bonus points, but for 2023, CMS has finalized that all clinicians who report PI must report on this measure. They also made a few tweaks to the language of the measure. It's being expanded to include Schedule 2 opioids and Schedule 3 or 4 prescriptions, whereas it had only included Schedule 2 in the past. Of note, 2021 AMA report found that physicians used state-run PDMPs more than 910 million times in 2020. So this really is to say that they are becoming much more widely used and accessible throughout the country. And that's really the rationale behind CMS making this measure required to report going forward in 2023. There are a few exclusions to the measure. So clinicians who are unable to prescribe these opioids for one reason or another under applicable law can claim an exclusion. Another scenario would be if you do write fewer than 100 permissible prescriptions for the specific opioid drugs during the 90-day performance period that you choose to report for PI. And then lastly, any MIPS eligible clinician where querying a PDMP would impose excessive workflow or cost burden. That exclusion is for 2023 only. So for any of these situations, if you were to claim any of these exclusions, the points from this specific measure of PI would be reweighted to a measure within a different objective. So this is a strategy where if you are not able to report this specific measure for any of these reasons, you can still report PI and just not do this measure. Okay, so for in the past in 2022, there have been automatic reweightings for several different types of MIPS eligible clinicians. In 2023, CMS has finalized that the following clinician types will no longer be automatically reweighted, so they will need to report PI, and that's nurse practitioners, physician's assistant, certified registered nurse anesthetist, and clinical nurse specialist. So if you hadn't reported PI in the past and you fall under one of these types, you will need to in 2023. And then on the next slide, it actually lists out the types of clinicians that will continue automatic reweighting. So if you fall into this category and you haven't reported PI, you again in 2023 will not be required to report for the PI category. And then I'm going to toss it back over to Mike.
Sure, great. This is a good time to get questions. We've already gotten a number of them in, but please ask your questions away. Looks like we will have time at the end to answer questions and maybe end a little early. If not, we are flying through these slides. The first part here is MVPs are here. We have been waiting for this for a number of years. They have pushed it back. They've talked about it for a number of the final rules and proposed rules as something that is coming for the future. So things that are going to happen with MVPs. MVPs were created to simplify MIPS clinician experience. So it's going to improve the value, reduce the burden. They really want you to understand that they are doing this for a benefit, and it's not any more difficult than MIPS. It's giving you less measures. It's giving you the opportunity to report on things that are most likely to happen within your practices and location. So MVPs are here to capture the patient voice. So understanding and helping clinicians and practices move forward towards APMs as well. The ultimate goal is that by 2030, I may have it on another page here, but by 2030, CMS wants all payers to be, all Medicare providers to be in some type of value-based arrangement. In response to clinician feedback that choosing measures and understanding requirements are confusing and burdensome. It's also in response to clinician concern that MIPS does not allow for sufficient differentiation of performance across practices due to quality selection bias, really comparing providers to each other so that patients can make a decision on where they want to go. The current MIPS does not do that. However, they believe by comparing them on the same measures that it will be more responsible on their part for providing information to practitioners and clinicians. The intention is to focus on MIPS, on MVP development and implementation. And this is the big one. The plan is for MVPs to become the only method to participate in MIPS in future years. CMS has not established a date or timing of the sunset of traditional MIPS, but the ultimate goal is that MIPS, as you see it today, will disappear as MVPs come in. But I'll put a caveat on that one. It took 4 years for MVPs to come, so I've got a feeling it's going to take longer to get rid of MIPS, as well as MVPs really is MIPS. There's not a terrible ton of difference between the two. Very similar scoring policies. The biggest differences are how you're compared to your peers. All right. So the MIPS value pathway framework, how it works. You can report as an individual, single specialty groups can report, multi-specialty groups can report, subgroups and APM entities can all report through the MVP. There's been 5 new MVPs finalized in 2023, as well as revisions to the 7 current ones, and we'll go over those the next page. MIPS value pathways, basically the whole deal is that you have to have at least one cost score. You're going to have to choose 4 quality measures. Most of the MVPs have many more than that to choose from, as well as your normal improvement activities. And they all lay on top of the foundation of promoting interoperability, as well as those patient population health measures and enhanced performance feedback with patient-reported outcomes. So there's a foundation that every MVP needs to have those, as well as those 3 pillars that you see on top. That's how MVPs are going to move forward and how they are going to score. For the MVP finalized measures here, We are looking at the new MVP measures: advanced cancer care, optimal care for kidney health, optimal care for patients with episodic neurological conditions, supportive care for neurodegenerative conditions, as well as promoting wellness. I think that you'll find the newer MVPs are allowing more of different specialties into the MVP area, and that you'll be able to see from this point that MVPs are going to be spreading out more and more as the program grows and as they come up with new cost measures associated with them. So this is an example of what it looks like if you are to report through multiple different mechanisms, whether you're reporting MIPS as a group, a subgroup, or individual reporting. So what you can see here is the example up at the top is the participation type. So the full group, you have A through G. They got a score of 90, reporting through an MVP. You have a subgroup, ABC, that is reporting another MVP, and they got an 80. You have a second subgroup with only a number of providers that is reporting the heart and disease MVP. They scored a 97. Then you have three individual providers that are also reporting traditional MIPS, and you see their scores there. CMS will take the highest of all of your scores, no matter how you report through these systems. So you could see that provider A here will get their final score of 98 because as an individual, they scored higher than any of the other groups they're in. B gets a 90 because the full group score is higher than the subgroup. Provider C, the full group score is higher, so they'll get the 90 as well. And then as you see down below, like provider E, only the full group score is available for them, so that's what they get. Provider F, the subgroup score is higher than the full group score. And then provider G, who is in a subgroup as well as the full group and an individual score, will get the highest of those three, which is that subgroup number 2 that they're part of. Little confusing, but if you need, we are working on creating areas for you to be able to understand what this looks like in calculators that are going to help you. So moving from MVPs over to ACOs, as I stated before, we had a webinar last week that went over ACOs and how they score. If that's what you're interested in, I highly recommend going to the top right-hand corner of our homepage, healthmonics.com, and clicking on the webinar section, and you will be able to download the slides as well as see the video for the webinar. There were a lot of changes with the APP this year and how they are going to move forward, but the main thing is that ACOs are going to need to report through the APP and ECQM, CQM categories instead of reporting through the web interface, which will be gone in 2025. So there's a new sliding scale for ACOs. It helps with the change from the web interface over to the ECQM, CQM reporting. They also, here's the word again, they added a new health equity adjustment to reward ACOs reporting all payer. So if you are making those changes, they're giving you an opportunity to score better on it. The requirement of getting rid of the CMS web interface in 2025 has continued, extending the incentive reporting period. So there is an incentive for reporting these ECQMs through the performance year of 2024. They also are adding a new consumer assessment for healthcare provider system. So they are changing the caps for MIPS survey questions, as well as they are increasing participations in accountable care models in underserved communities. So they are really, really looking at these underserved communities so that they can get a better handle on their lowest categories, lowest underserved patients, sorry. Here's an example. I'm not going to go through it all, but the options in 2023 and 2024 are the same for MIPS for APP reporting. You either can report the tenant CMS web interface as well as the ECQMs. If you do either one, you can see down the bottom the options that you have. The big differences in performance year 23, you need to be in the 30th percentile, and performance year 24, the 40th percentile. And then as you can see for 2025, they have eliminated in full the CMS web interface, and you need to score in the 40th percentile so that you could be part of the savings. One thing over last time for the health equity for all, CMS is working towards advancing health equity by designing, implementing, and operationalizing policies and programs that support health for all. So these programs are eliminating avoidable differences in healthcare outcomes experienced by people who are disadvantaged or underserved. Health equity is not healthcare that everybody gets the same healthcare. It is meeting the healthcare needs of each individual patient and how they are working. I explained it to my team in an internal call the other day. It is like if you are at a baseball game and there are 3 people in the outfield, all varying heights, one at 5 foot, one at 5'8", and one at 6 foot tall, and you gave them the same size carton to stand on top of to see over the fence. That's not health equity. That is equal health. Health equity means that you would give them the appropriate size carton to stand on so they could all see the field at the same time through the same direction. That's the big difference for people kind of just picking up on where this health equity is. So the highest level of health for people everywhere, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language. If you want to talk health equity, is amongst my favorite topics right now. And just give me a call and we could talk it out, because I think I have a lot to share on it. And then I am going to turn it back over to Mara, as we've had a ton of questions come in. So I'm hoping that we can get a chance to get to most, if not all, of these things.
Cool. Thanks, Mike. So quickly, just want to go over kind of next steps for determining your strategy. As we do approach the end of the year, it's definitely time to determine how you want to and how you will report for 2023 MIPS. So why would you use a registry? There are many reasons to pursue registry reporting with a product such as MIPSPRO. But bottom line is we can help you maximize your ROI by reporting on measures that are more relevant to your specialty. With over 200 measures supported, we can help you choose the ones where you score best and ultimately report those and improve your ROI throughout the year. Our technology allows for the combination of many different data sets across healthcare platforms, whether that be EHRs, billing systems, anything like that. Whether you're a large hospital system that has 5 different EHRs, or if you're transitioning throughout the year, any of those scenarios we're very well versed in combination. But on top of our technical capabilities, we are the MIPS experts, so we are here to guide you through changing program requirements as we move into MVPs and APMs or anywhere else that CMS might take us over the next few years. We are here to guide you through that. We've read the final rule, we know what's in it, so we're happy to help everyone out with that as we go. Next slide. Okay, so what to do today? Choosing quality measures is an important first step. So reviewing what measures you've used in the past, evaluating past performance on those measures is helpful to determine a future strategy and know what measures you'll use going forward. Meet internally to discuss MIPS. This presentation would be a great resource to present to your staff and get everyone on the same page of where MIPS is going in 2023. And then lastly, get the right tools in place. So if you're using MIPSPRO, determining what data you'll use and how you're getting it to us is an important first step, and you want to make sure you have that done before the beginning of the year so that we can help you all year long.
Sorry.
You're good. Our MIPSPRO product does offer live dashboards. So as soon as we receive data from you, it populates into your dashboard, shows current MIPS performance across all providers. And then from there, our tools make it really easy to identify and close gaps in care and ultimately improve your overall MIPS score and, of course, reimbursements as well. One thing we pride ourselves on is really how user-friendly our product is. So it's definitely designed to help our users understand their performance in real-time data so that you can make actionable changes throughout the year and ultimately improving the quality of care that you're delivering to your patients. Yeah, so our goal is really to reduce the burden of this program, really kind of make it as straightforward as possible. So, with that in mind, our US-based support team is available all year long to assist users of MIPS Pro with technical questions, program requirements, or any sort of MIPS questions that come up throughout the years. Programs change. We're here for all of it and happy to help all of our users again navigate this complicated program. With that, I will hand it back over to Mike to discuss MIPS cost analytics.
Sure. This is also a great time for you to ask your final questions as we will be going through them. I only have 2 or 3 more slides to go. And this is just a base example of really having people understand that MIPS, that cost is coming. It is here. It has been a number of years since it really was relevant. I have been familiar with the program since it was part of the value-based modifier where it was combined with the quality score back in the day. As they introduced the cost score, it was a very small portion of what your overall score was. It started out at 10% of your score, and you really only needed at that time to get 30 to avoid a penalty. So no one really took it as being something for real. In 2019, 2020, and 2021, CMS has taken it out of consideration and wasn't counted towards your score at all. And instead of making that ramp up period restart again in 2022, CMS has it as the full blown 30% of your overall score. So if you think about all of the time that you spent on quality scoring, you can understand that in 2022, quality and cost, if you are eligible for any of the measures, will be 30% of your score. So we've built a product called MIPS Cost Analytics. This product will allow you to estimate your MIPS cost score throughout the year, provide actionable insight into each of the cost measures now that there are so many of them, and there will be more built into the future that more specialties are going to be associated with. Identify your anticipated attributed patients and episodes. We also dig into individual claims-based measures. So we're sharing your individual patient HCC scores. And then finally, allows you to easily identify those patients and providers that have the largest impact. So are they your diabetic patients? Are they your patients that are 85 and over? Are they your patients that are dual eligible for MIPS and Medicaid? I mean, Medicare and Medicaid. We have the ability to track a lot of that information for you and provide you that information to drive growth. Just a reminder that 2022 is the last year for exceptional performance bonus, so it's not around next year. I will say on this note, when we showed that graph, you'll see for the first time there is no curve to that graph. It is a straight line graph. So while we're getting rid of the exceptional performance bonus in that year, there is no bump up at 89 points, which there was in 2022. In 2023, it will go straight from the 75, which avoids the penalty, up to 100 straight. Stay tuned for our next webinar coming up. Our next webinar will be in December. We actually, I believe, have 2 or 3 that are coming up during that period of time. So stay tuned for that. Once again, if you need our contact information, here's our information that we have. I'm going to run through some of these questions. There were a bunch. Some of them are relevant to everybody, so I will answer those questions there. So the first question is about the new measures and the maximum points, 10 points, or will they stay at 3? There's actually new requirements for the measures that we didn't go over on this call. We did go over it on our previous webinar for what to do in the last 90 days. We did in that webinar, as well as some of the overviews that we did last year, but there are new point requirements where if you are a new measure, the lowest amount of points you can get is 7. If it's a second year for a measure, the lowest points you can get is 5. They are attempting to get providers to clinicians to report new measures in 2023 and moving forward. So they are offering them bonus opportunities for that. The next question was about cost. What do you mean by cost improvement maximum of 1%? So think very similar to the quality category, where they, if you improved by a certain percentage, they would give you an amount on top of your quality score. And so for cost, they're doing the same for this year. So if you are scoring well, and it's based upon each measure, you will get up to a 1% bonus on your score. Not sure where that will take you with being only 1%, but it is something, and since it will be harder to score well in each of these measures, it's giving you an opportunity to score a little bit better. There was a question about exceptional reporting in 2023. I think I just went over it there for a minute, but for MIPS are strictly based on revenue neutral payments. So it is a true losers pay the winners. Anybody that's below that 75 point threshold will pay into the pot, and those that are above it will receive a bonus. I know for the last couple of years that bonus has been very small due to the pandemic. However, I do believe as they get rid of more and more of these opportunities to get out of MIPS and reporting, they will give you that number will come higher. Sorry for mumbling there, but that number will become much higher, and you'll be able to actually make some incentive on this program more moving forward if you do very well. So for the PDMP, do every eligible clinician need to do it? Yes. So the PDMP, every eligible physician needs to do the PDMP. You only need to do it during your 90-day period. I guess they're trying to get you to do it for the whole year, but you only need to do it, your PI only needs to be done for 90 days at a minimum. So you need to do it during that period that you are reporting. There are a couple outs. There's kind of an easy out there of it's too burdensome for you, but just be careful. I'll tell everybody on taking exemptions and exclusions moving forward, as CMS is realizing that I believe that they are realizing that they are being taken advantage of on some of these, and that people should start making sure that they are fully participating in 2023 and beyond. There was a question about an individual provider and whether they need to report and their eligibility. There are a lot of eligibility rules and timelines, and not knowing when they started Medicare and how they will start Medicare and getting claims, there are timelines that those things will show whether you need to participate or not. The main thing that I would do is either go to our webpage or go to qpp.cms.gov, and you can look up the provider and it will tell you if they're eligible or not, as well as give you the date ranges that they're currently tracking for. So that does give you an opportunity to do that on an individual basis. The next question, what year does CMS want providers to be in value-based care arrangement? That was 2030, which seems like a million years away, but it's actually only seven more final rules away. So I've been through enough of them so far. I could tell you that that is not terribly far away. Are small practices automatically reweighted to quality for PI, yes, if you are 15 or fewer providers, you are automatically reweighted to quality from the PI section. Actually, it's not all towards quality. If you are PI exempt, some of that will move into IA and cost. I have the breakdown on my previous webinar that I did, and I can share with what that looks like. However, I do recommend taking a look at what you've done in PI, and if you've scored well in PI throughout the years, and it's scoring better than your quality score, I myself would still report your PI because it will help your score overall. So regarding MVPs, it really in 2023 for MVPs, there are the distinctions of different groups. This one's asking about 2 different types of providers within a group. It matters how you're fitting in for each of the measures. You need to make sure that you have the 20 in the denominator for each of the measures that you need to report on. And we do have the ability to take a look at that for you on an individual basis. That looks like most of the questions that I can answer on the call today. Once again, I really want to reiterate to everyone that there is a lot of similarities between 2022 final rule and 2023 final rule for MIPS. However, I would pay attention to those few changes that we share with you, as they will really give you the opportunity to maximize your score, avoid the penalty, and hopefully get some of that incentive. If you have other questions, please feel free to reach out to me. The contact email that you see on the page goes directly to my email inbox, and I'll be happy to help you where I can. If you have any other questions, please reach out. Have a wonderful day. Have a wonderful holiday and Thanksgiving week, and we will talk to you in December. Thank you. Thanks, Mara, for helping.
Thanks, Mike. Thanks, everyone.
Bye-bye.